Everybody, greetings and welcome. This is another episode of Minutes to Mastery, and I thought today we'd talk about status epilepticus because we had a patient come in recently with that, and you'll get a little video of our airway management of that patient clipped onto this. Status epilepticus is an important condition to treat because there's an urgency in its treatment. Its definition is that you'll have 2 or more seizures without complete resolution between seizures, or you can have more than 30 minutes of seizing activity. It's very important to control the seizures early because the longer they go on for, the more refractive they are to treatment and the greater the chance of mortality. So a seizure lasting less than an hour has a mortality of about 2.7% associated with it, whereas seizures greater than 1 hour, the mortality increases above 30%. The way we approach these patients is we get them to a resus cubicle, make sure we manage their airway, their breathing and their circulation as we normally would. The treatment is benzodiazepines and phenytoin, and really the benzodiazepine of choice that we use is midazolam, so we can give an intramuscular dose of 0.2 milligrams per kg, and that will control most seizures, and we'll phenytoin load these patients. So in phenytoin we're using about 20 milligrams per kilogram, so that's about 1 gram. We give it over an hour because one of the main side effects of phenytoin is that it causes hypotension. It doesn't matter if the patient's already on phenytoin, there is no harm done to the patient by phenytoin loading them above their normal dose.
Okay, fine, we'll get bloods, we'll get a 12 lead. If his dilantin's low, then we'll load him with phenytoin.
No worries.
Okay, wonderful. Do we know when his last seizure was? Did the ambulance say?
October.
Is this another seizure?
Give him some more midaz. Give him another 2.5 of midaz.
Yep.
I got it.
Got it.
Right. 2.5 just now?
Going in as we speak.
Right.
Okay, in.
It doesn't look like it's...
2. 1. No, just this left arm.
What you might tend to find with these patients is that there's a predisposition for patients without epilepsy to be coming in with status epilepticus, and it tends to occur in the extremes of age. So about 50% of your patients with status will be children, and a significant number will be over the age of 60 years of age, so you need to understand your dosages. If the seizure is refractory and it doesn't stop, you then need to take further action. And really the mainstay, as I said, is going to be the benzos. You can try benzodiazepam rectally in children, although that has a slow absorption and midazolam is preferred. As we increase the doses of benzodiazepines, we tend to be faced with an airway problem in these patients, and so in many cases we take control of the airway and we use a neuromuscular blocker and we'll use some barbiturates and we'll intubate the patient. The care then becomes that if we're using a neuromuscular blocker, you've got to be very careful that we're masking the tonic-clonic activity of the seizure, but that there may be still neuronal seizure activity going on. That can also occur if we've given benzodiazepines and you've seen the tonic-clonic component of the seizure stop. But the patient can still be tachycardic, and if you look at their eyes, they may have a deviation of the eyes to one side. You've got to be very careful with these patients because they're still seizing neuronally, but they don't have the tonic-clonic component of that seizure. All of these patients that progress and are refractory will need to have high-dose benzodiazepines. They'll need to be intubated, paralysed, and they'll need an ICU environment, obviously. So that's status epilepticus. You need to get control of it very, very quickly, and you need to use optimum doses of drugs. This is Peter Cass. Here's another week. I'll see you next time for another talk. Bye for now.